Hello everyone. Uh, in this following few minutes, we will be discussing about binocular single vision. This is the part. I have divided it into two parts, part 1 and part 2. So after these two parts, you will be able to answer all the questions related to binocular single vision. I am sure there will be no questions left unanswered in your mind. Alright, so let us begin. What is definition? How you define binocular single vision? When a normal individual fixes visual attention on an object, the image is formed separately on the fovea of the both eyes, yet the brain perceives a single image. This phenomena is known as binocular single vision. Visual development of binocular single vision. Binocular single vision is a conditioned reflex. This is we all should know. It is not present at birth. It begins to develop during the first 6 months of life and it becomes fully established during the first few years of life. Important milestones in the visual development. At birth, there is no central fixation and eyes move randomly. Okay. By 1 month, fixation reflex begins to develop. By 6 months, fixation reflex is well established. Macular stereopsis is fully developed and accommodation reflex is fully developed. And then by 6 years, full visual acuity is attained and binocular vision is single vision. Binocular single vision is also well developed. Now, coming on to the prerequisites for development of binocular single vision. First of all, straight eyes from the neonatal period requires precise coordination of extraocular muscles, proper alignment in all directions of gaze and represents the motor mechanism. Second prerequisite is reasonably clear vision in both the eyes. So this means similar images must be formed on each retina. It requires clear visual axis and a good retinal function. It represents the sensory mechanism. Third prerequisite is the ability of the visual cortex to promote binocular single vision. How? By integration and fusion of images from both the eyes, and this represents the cortical process. Okay. Now, what is the clinical significance? Any pathological condition which affects the motor, sensory, or the cortical mechanisms during the first few years of life will interfere with the development of binocular single vision and may lead to squint or strabismus. Now, coming on to the pathologies affecting the mechanism of binocular single vision. So we know what are the prerequisites for binocular single vision. Now we will understand the pathologies affecting the mechanisms of binocular single vision. First of all, it is the motor pathway. So pathology can be congenital strabismus or extraocular muscle palsy or third, fourth or sixth cranial nerve palsy. So it causes a defective motor alignment and hence defective coordination of the eyes, so which results in ocular misalignment, initially diplopia, and then causes suppression of one eye, and consequently it results in the squint and the loss of binocular single vision. Okay, coming on to the sensory pathway. So sensory pathway, in this the pathology is either a congenital cataract or a corneal opacity or a severe refractive error or anisometropia. It produces poor or unequal retinal images which result in the failure of sensory fusion. Therefore, amblyopia also causes loss of stereopsis and hence absence of binocular single vision. Okay. Third is the cortical pathway. In this, the pathology is usually the cortical visual impairment, cerebral palsy, developmental delay, or the hypoxic brain injury. This results in defective cortical fusion and interpretation, and this results in the inability to integrate the images and therefore failure of binocular single vision. Okay, now let us learn with some clinical case examples, the pathology, the mechanism and the outcome. So the first case is a 6-month-old infant is brought with inward deviation of both the eyes noticed since birth. So the pathology seems to be most likely is congenital strabismus. So the affected mechanism, as we have discussed, is the motor mechanism. That is the poor ocular alignment. This is a prerequisite, and this is not being followed. There is a poor ocular alignment. Proper ocular alignment is the prerequisite for binocular single vision, but here it is disturbed. So what is the outcome? There is a failure of binocular alignment, which leads to suppression, which develops to separate. Therefore, the child develops suppression to avoid diplopia, and hence there is loss of binocular single vision. Another coming on to the second example, that is the unilateral congenital cataract. So here the prerequisite that is not fulfilled is the sensory mechanism. How? So a 2-month-old infant presents with white pupillary reflex in one eye. So on examination we find that this is child is having congenital cataract. Affected mechanism is the sensory mechanism. So what is the outcome? There is a stimulus deprivation amblyopia in the particular eye having the congenital cataract. Therefore, there is no fusion or stereopsis 3D vision. Therefore, absent binocular single vision. Okay. Coming on to the third case, that is anisometropia. Anisometropia means there is high difference of refractive error between the two eyes. Okay. So there is high anisometropia. The mechanism is the same. Sensory mechanism is affected. Here there is amblyopia without squint. There is reduced stereopsis and there is impaired binocular single vision. Coming on to the fourth example, that is a sixth nerve palsy. So here a 4-year-old child presents with sudden onset inward deviation and face turn. So the pathology is, we can understand here is the abducens nerve palsy. It is a sixth nerve palsy, lateral rectus palsy. So motor mechanism is involved. So therefore there will be esotropia and there will be initially developed diplopia. Therefore, the mechanism to decrease diplopia, that is suppression, will come into force, and then there will be the loss of the binocular single vision. Then another is the cortical visual impairment. In this, there is the mental mechanism. A child with history of perinatal hypoxia has poor visual attention despite normal eyes. Here the pathology is the cortical visual impairment. Affected mechanism is the cortical fusion mechanism. Therefore, there is inability to fuse the images, pure stereopsis, and hence the failure of the binocular single vision. Now, grades of binocular single vision, this is very important. So binocular single vision is divided into 3 grades which are best tested using a synaptophore. So this is a synaptophore. This is how a binocular single vision grades are tested. This is the first grade, that is a simultaneous perception. You have to look in this. So in this case, we have to look here. You can see this is simultaneous perception. Okay, so what is this simultaneous perception? In this, there is this ability to perceive two dissimilar images simultaneously, one from each eye. Okay, so the test, that is synaptophore, is used. It projects two dissimilar but related images are projected separately to each eye. The images can be joined or superimposed to form a meaningful picture. For example, the right eye has the picture of a bird, and the left eye has a picture of a cage. So normal response is the bird seen inside the cage. So clinical significance, the absence indicates suppression of one eye, and it is the first and the most basic grade of the binocular single vision. Okay. Now coming on to the second grade, that is the fusion. So what is fusion? So this here you have to look here. So this is what fusion is looks like. Okay. So how you define fusion? The ability to superimpose two similar but incomplete images to form a single complete image, that is fusion. So each eye is shown a complementary part of the same image and the subject fuses them into one picture. So positive fusion, ability to maintain fusion on convergence, and negative fusion is the divergence, which is ability to maintain fusion on divergence. So in this case, you can see there is flower. This is doll with a flower. Flower is in the one of the right hand images shown to the right eye. And if the fusion is proper, you can see the girl with the flower in the same picture. Okay, so clinical significance, it indicates the stable binocular vision. It is absent in most manifest squints. Okay, now coming on to stereopsis. Coming on to the stereopsis, so you have to look at this. So what is here? It is the ability to perceive the third dimension, that is the depth perception. So stereopsis slide and chapter 4 are shown, and they require intact grade 1 and 2. What is the clinical significance? It is the highest grade of binocular single vision, and it's lost earliest in the strabismus. Okay. So basically, this is a table which shows three grades, the names along with the ability, what does they show, and examples. So this is just a summary slide for you guys to remember. Coming on to the anomalies of binocular vision. This is very important. So in this, I will only talk about suppression and amblyopia, and the rest we will be talking about in the next presentation. So first of all, let us study about suppression. What is suppression? Suppression is a temporary active cortical inhibition of the image formed on the retina of the squinting eye. Okay. What are its key characteristics? It occurs only during binocular viewing when both the eyes are open. It prevents confusion and diplopia. When the fixating eye is covered, suppression disappears. The suppressed eye then takes up the fixation, and hence suppression is a functional and reversible phenomenon. Okay. What is the mechanism? The brain suppresses the image from the deviating eye to avoid diplopia and visual confusion. It is commonly seen in the childhood squint. Okay. Now, which are the tests to detect suppression? We have the Wirtz 4-dot test, 4-diopter base out prism test, red glass test, and the synaptophore test. We will be studying about these tests later. Okay, so with the help of a flow chart, I have just tried to outline how in a patient with squint there occurs suppression, and hence which leads to amblyopia. So what is strabismus? It is a misalignment of the eyes. Therefore, different images fall on the non-corresponding retinal points. This leads to diplopia and confusion. Therefore, the protective response from the brain is generated, which results in suppression. So, in suppression, what happens? There is the active cortical inhibition of the image from the deviating eye. It occurs only during binocular vision and hence prevents diplopia and confusion. Now, if suppression persists during this critical period, there is a reduced visual stimulation of the suppressed eye, and hence amblyopia develops. Okay. Now, let us learn about what is amblyopia. Definition of amblyopia is very important. Amblyopia is a partial loss of vision in one or both the eyes occurring without any organic disease of the ocular media, retina, or visual pathway. Okay. So what is the pathogenesis? It is caused by amblyogenic factors acting during the critical period of visual development, that is from the birth to the 6 years of age. So most sensitive period is up till the 6 months of life. Amblyopia usually does not develop after 6 years of age. What are the amblyogenic factors responsible? One is the visual or form sense deprivation, example anisometropia. Light deprivation, like sensory deprivation, that is the congenital cataract formation, abnormal binocular interaction in cases of strabismus. These are the amblyogenic factors. Now, coming on to the different types of amblyopia. First of all, it is the strabismic amblyopia. It is because of the prolonged uniocular suppression occurs in unilateral squint, and fixation is with the normal eye. Second is the stimulus deprivation amblyopia. Eye is totally deprived of vision in early life. It can be because of congenital or traumatic cataract or complete ptosis, dense central corneal opacity. Coming on to the anisometropic amblyopia, it occurs in the eye with higher refractive error, more common in anisohypermetropia than anisomyopia. So important exam points are 1 to 2 diopter hypermetropic anisometropia can cause amblyopia, but usually myopia up to 3 diopters does not cause amblyopia. Isoametropic amblyopia, there is bilateral amblyopia due to bilateral high uncorrected refractive error. Okay? And then there is this meridional amblyopia. It is due to uncorrected astigmatism. Selective amblyopia affecting a specific visual meridian. Now, clinical characteristics of an amblyopic eye. This is very important. So, first of all, the clinical characteristic of amblyopic eye is there will be reduced visual acuity. This is basically how you recognize that this eye is amblyopic. So, there will be reduced visual acuity. Okay? Recognition acuity affected more than the resolution acuity. Then effect of neutral density filters. In neutral density filters, the visual acuity improves by 1 to 2 lines in amblyopia, but it worsens in organic lesions. I will discuss about this in the next slides. Crowding phenomena, here visual acuity is worse with multiple letters on the Snellen chart, and it is better with a single optotype, which is diagnostic of amblyopia. Then another is the fixation pattern. This may be central or eccentric. Severity is associated with distance of eccentric fixation from the fovea. Color vision is usually normal. It is only affected in deep amblyopia when the vision is less than 6 by 36. So these are the neutral density filters. So physiological basis of neutral density filter effect in amblyopia. This physiological basis of neutral density filter effect in amblyopia is a very important concept. So what is the key concept involved? So key concept is in the definition of amblyopia. Amblyopia is primarily a functional disorder of the visual cortex, not a defect of the retina or the optic nerve. So it is the functional disorder of the cortex. There is no pathology of the retina, optic nerve or visual pathway. Okay. So what happens in organic disease and what happens in amblyopia? So first of all, in organic disease, retina or optic nerve is structurally damaged. Therefore, vision depends on the maximum light input. Okay, so reducing light with a neutral density filter, it reduces retinal stimulation, it decreases the signal transmission and hence worsening of the visual acuity. But what happens in amblyopia? Retina, optic nerve are normal. So where problem lies in cortical understimulation, poor neural processing and unstable fixation and attention. This is what happens in amblyopia. So how neutral density filters improve the visual acuity? Number one, there is a reduction of excessive light. Neutral density filter reduces overall luminescence, therefore minimizing the glare and the light scatter. They improve signal to noise ratio. There is less background noise. Visual cortex receives the clearness signal. Usually, amblyopic eyes have unstable fixation, but the reduced luminescence improves the fixation control. Second is another thing is the increased cortical attention. Reduced brightness helps concentration, enhances cortical response to the visual stimulus. And fifth is the recruitment of underused cortical neurons. Previously suppressed cortical pathways become more responsive. So why this does not happen in organic lesions? Because the lesions produce photoreceptor function and axonal transmission. Any reduction in light reduces the stimulation and hence worsens the vision. So that is why visual acuity improves by 1 to 2 lines in amblyopia. So this is just a step-by-step physiological explanation how visual acuity improves by 1 to 2 lines in amblyopia. How? Because amblyopia there is number one unstable fixation. So neutral density filters with their ability to decrease the luminescence improve the stability of the noise, stability of the eye, decreases the noise as well as minimizes the glare and the light scatter and helps enhance cortical response to the visual stimulus, therefore improving the visual acuity by 1 to 2 lines in amblyopia. Now coming on to the crowding phenomena in amblyopia. So what is the crowding phenomena? It is disproportionate reduction of visual acuity with multiple optotypes compared to single optotype of the same size. Okay, so this is a single optotype. There is better visual acuity and there is no crowding phenomena, and crowding phenomena is present when multiple optotypes are seen. So why? Because number one, there is defective cortical processing in patients with amblyopia. Amblyopia is a disorder of the visual cortex, so there is difficulty in separating adjacent visual stimuli. Second, there is reduced spatial resolution. There is poor ability to recognize closely spaced objects. Number third, there is abnormal lateral inhibition. There is interference from the neighboring letters and individual letters cannot be perceived distinctly. Then attentional and fixation instability. Fixation is less stable in amblyopic eye, therefore multiple letters increase perceptual confusion. Okay. Now, just few uh, just few slides for treatment of amblyopia. General principles of treatment is treatment should be started as early as possible. Younger the child, better the prognosis. Occlusion therapy is the mainstay of the treatment. Coming on to the prerequisites before occlusion therapy. If there is any media opacity, cataract, congenital cataract or corneal opacity, it must be addressed, and refractive error, if present, must be fully corrected with appropriate spectacles. Occlusion therapy, it works on the principle of occlusion of the sound eye, that is the normal eye, and forces the use of amblyopic eye, and hence stimulates visual development in the amblyopic eye. Now, this is a simplified age-based occlusion schedule. Up to 2 years, 2 days sound eye and 1 day amblyopic eye, 3, 4, 5, and after 6 years, 6 days occlusion of the sound eye and 1 day occlusion of the amblyopic eye. So, occluding the amblyopic eye intermittently helps prevent occlusion amblyopia of the sound eye. So, that is why this is the simplified age-based occlusion schedule. Now, Now this is a graph. So this shows how the corneal plasticity, occlusion risk and occlusion ratio versus age. What is the younger the child, the more plastic, that is malleable and sensitive the visual cortex is. At the same time, the risk of producing occlusion amblyopia in the sound eye is higher in younger children. Hence, occlusion must be balanced according to the age. So what is the physiological basis for this? Cortical plasticity varies with age. In infants and young children, visual cortex is highly plastic. Even short deprivation can cause amblyopia. In older children, greater than 6 years, cortex is less plastic. Basically, 8 to 9 years we tell. So, longer occlusion is needed to stimulate the amblyopic eye. Then coming on to the risk of occlusion amblyopia, continuous occlusion of the sound eye can cause reverse amblyopia. So it is highest in children less than 2 years and lower in older children. Therefore, intermittent occlusion of the amblyopic eye is included in the younger ages. So in this, as the age increases, the plasticity, you can see the cortical plasticity, this is decreasing. So therefore, the risk of reverse amblyopia also decreases. So therefore, the occlusion ratio increases. So therefore, 6 days of occlusing the sound eye is there, and 1 eye occlusion, 1 day, that is occlusion of the amblyopic eye, is done. So this is very important for you all to remember and understand how occlusion therapy is important, how much occlusion is really necessary because of the cortical plasticity being at play. Now coming on to the duration of occlusion. Occlusion therapy should be continued until visual acuity develops fully or until no further improvement in vision is seen for 3 consecutive months. So monitoring, the regular follow-up is essential to assess the visual acuity, compliance and signs of the occlusion amblyopia. Very much thank you for your patient listening. We'll meet you in the next presentation. Thank you very much.